Fantastic. All right. So projecting nicely. Very good. Well, hi everybody. Most of you already know me. Some of you not yet, but you'll get to know me. I am going to talk about today about the new treatments coming up for patients with Waldenstrom's. All the big effort made in the laboratories of Dr. Carrasco's and Trion's and at the Mayo Clinic and other places in the world really come down to this, to the development of new treatments that will affect patients in a positive manner, treatments that are easier, less toxic, more convenient, and hopefully get to the point in which we can actually cure this condition. So I just want you guys to think about how much IgM there is in this room right now. That's a lot of IgM. All right, probably the room with the largest IgM anywhere in the country at this time. All right. Let's talk about this. Now, my email address is there. I always leave it in there just in case you would like your clinicians to get in touch with me. If you're my patient, you know that you can email me directly at any time and you'll have my attention 24/7. Now, you typically get back to you within 12 hours because I have to sleep. If you're not my patient, please feel free to give your contact to your doctor so your doctors can reach out to me directly. I cannot, unfortunately, provide specific recommendations to patients that I have not seen formally in consultation. So I hope you understand all that. Very good. So you have seen this before. This is how Waldenstrom's can affect sometimes patients in so many different ways. This is interesting because when you think about the clinical manifestations of Waldenstrom's, everybody is so different. We do have patients, for example, who have hyperviscosity. Those patients almost never have neuropathy. The patients with neuropathy are almost never anemic. Right? So there is something about this disease that presents so different from patient to patient. So there must be some other differences as well in the background, and we know that based on the work from our laboratory showing that there are different mutations and different pathways that are activated in some patients and might not be activated in some other patients. So there's a lot of heterogeneity out there. Having said all that, we all call this disease Waldenstrom's, even though clinically speaking, there actually might appear there could be different diseases. So this is the importance sometimes to see or be seen by a physician with a little bit more experience in these type of conditions, because it could be a little difficult even for the regular hematologist to understand the little nuances that this condition carries in terms of treatments. But why don't we have to treat everybody at the time of diagnosis? And I think in a simple way, the best simple way I can put this is there are three reasons. Number one, as of today, Saturday, I think it's about 2 p.m., 1:43, we don't have a cure for Waldenstrom's. So we are not treating patients with the objective of curing, number one. Number two, patients with Waldenstrom's, as you saw earlier in the presentation by Dr. Matos, are expecting really long survivals. The large majority of patients are expecting long survivals. And so therefore, if we're going to have that survival that is so long, how much do you think a treatment that lasts 6 months is going to affect 10-year or a 15-year survival? It's very unlikely to do that. So in most cases, we don't prolong the life of our patients. The patients are going to have a long survival regardless of what we do. And every time we treat, which is the kicker at the end, every time we treat and we can send the disease in some type of remission that can last long, the disease might come back at some point in the future, right? And that disease, the one that comes back, is just a little bit different than the one that we treated at the beginning. So we promote resistance with our treatments up to some degree. So for those three reasons, if you do not have to be treated, then you're better off left untreated. And we need to be very careful, because when we make the decision to treat, it should be to improve the patient's quality of life. But for that, there are two aspects. Number one, the quality of life of the patient has to be affected in some way, measurable. Number two, which is very important, we need to prove that it's the disease that is driving that problem. Because we have seen in many situations how immediately it's assumed that the disease is what's driving a specific symptom that the patient might be having. And under deeper understanding of the disease, we realize that it's not the problem. And in those scenarios, the worst thing I can do is actually give you treatment, because that can give you more other side effects and other problems and more resistance associated with this process. So we typically follow these guidelines. These are the guidelines that Dr. Trion was alluding to earlier in 2002. A bunch of people got together in Greece, started sipping wine, and then realized that they should put some guidelines to treat patients with Waldenstrom's. And these are the guidelines that we tend to follow. They have not really been modified for the last 14, 15 years. And we have anemia, which is probably the most common reason why patients need to be treated. We do have low platelets, which is a weaker recommendation, but that was included in that place as well. Symptomatic hyperviscosity, as what Dr. Matos was alluding to earlier. The neuropathy, which is challenging in our patients. And patients can have other manifestations that are even more rare, like enlargement of lymph nodes, or enlargement of organs, or renal involvement, or pleural effusions, or even the meningitis secondary to Waldenstrom. So there are many different ways in which this disease can affect patients, and we should treat patients only when patients have symptoms bad enough driven by the disease, depending on what symptom the patients are having. So Dr. Trion touched on a number of other treatments that are available at this time. So what I'm going to be talking about with in this context is the newer treatments that are recently just came out in terms of results from clinical trials, and clinical trials that are ongoing. You know that if you are interested, obviously at the time, if and when you need to be treated, then things that you could potentially consider in the future. So this is the future of treatments for patients with Waldenstrom's. So we all know there is a family of medications called proteasome inhibitors that have been shown to be very effective in patients with Waldenstrom's. In this table, I'm putting at least 4 clinical trials that have been done in the past. And 3 of them is actually with bortezomib or Velcade, which is probably a medication that some of you have received. And we have our treatments. This is the first study that we did at the Dana-Farber. We have a weekly Velcade study that was done by the Greeks, and we have another study done at Dana-Farber by Dr. Ringobriel. So, I mean, you can see here what is the high rate of response. Our response is actually decreasing the IgM level by about 25%. That's how we measure response in Waldenstrom's. And the major response is very high too. Major response is decreasing the IgM by at least 50%. So those are really nice, deep responses. And when you look at the progression-free survival, if you remember what Dr. Matos was telling us, how long does it take for 50% of the patients to progress? And in this case, we can see that it can extend to 4 or 5 years for half of the patients to progress, which means the other half goes beyond that time without progression. So really, really effective, deep responses and durable responses. The last row here is carfilzomib. It's a medication that is approved in the United States for myeloma, and there is a study that came out in Waldenstrom's. It's a second generation proteasome inhibitor, and it tends to cause less neuropathy. Bortezomib is characterized by neuropathy problems in some patients. Carfilzomib doesn't give you that problem, but it's an intravenous treatment, and it has other problems too. It can increase your blood pressure, it can increase your sugars, can increase your cholesterol, and can give you other problems as well, but highly effective with a nice progression-free survival as well. So recently we have published a clinical trial on a new generation proteasome inhibitor called Exosomet that is already approved in the United States for myeloma. I think it's going to be probably part of the guidelines for Waldenstrom's later this year. We have I don't know if you're familiar with the National Comprehensive Cancer Network, or NCCN. Those are the ones that kind of put the guidelines for treating patients with cancer out there. We have a meeting in May, and probably this trial is going to be included in that list and could potentially be available for patients. So this Exosomet medication is essentially a pill form treatment that is taken once a week, and this is very similar to Velcade. It's actually an oral Velcade. Now, with that being said, as the medication is given by mouth, the risk of neuropathy is much, much, much lower, as you will see later. So in this study, we combine Exosomet, dexamethasone, and rituximab, very much what we have done in the past as well. And Exosomet was given once a week, 3 weeks on, 1 week off, so it's very easy to take. Rituximab, well, that continues being intravenous. In most cases, there is a recent subcutaneous formulation, but there's no study yet published on subcutaneous rituximab in Waldenstrom's, although I believe it's potentially usable in that scenario. So 26 patients were included in this study, and as you can see here, a very typical features of patients with Waldenstrom's with a median age of presentation in the low 60s. Most were men up to some degree. That's very common in Waldenstrom's as well. IgM about 45. That's, it says 4,500 there, but we'll use 45 for the Canadian units. Hemoglobin about 102, which is 10.2 in American units, but it's 100.2 in your units. So a very typical group of patients with Waldenstrom's. Now, in this study, for some reason, everybody was MYD88 positive, so really there's no data on Exosomet on MYD88 wild-type patients. I do not believe there's any reason why the patients with wild-type disease will not respond to this. I think they will. But in the study, there was no Mid88 mutated patients. And about 60% of patients had CXR4 mutations. 60%. We have seen, we have heard from Dr. Trion that about 30 to 40% of patients with Waldenstrom's have this. So for some reason, in our studies, we tend to have more CXR4 mutated patients. And I don't know if it's just luck of the draw or what it is, but 60% of patients on this study had the CXR4 mutation. And we can see here on the left the IgM mechanics and how it essentially drops over the first 6 cycles of induction and then continues dropping over the following 6 cycles of maintenance to get at a point that is about 1,000. That's the median, when the median initiation IgM was about 5,000. So that's a nice response. And on the graph on the right, we see the hemoglobin levels increasing from about 100 in average to about 130 points in average when we look at the entire group. So these are markers of efficacy in terms of IgM decrease and hemoglobin improvements. Now the progression-free survival, at this time we had about 18 months follow-up, so that will be probably around here. That's where about 90% of patients had not progressed yet. It kind of drops a little bit at the end, and this is a statistical issue because you can see here that only 6 patients being followed here, which means not everybody got to the 2-year mark of treatment yet. So this is going to be updated once half of the patients had progressed. We are now about almost 4 years out from initiation of the study, and we have not gotten yet to the median progression, meaning half of the patients, more than half, are still without progression until this time. So this graph is going to look a little bit different because we're going to have more follow-up on these patients. But what we saw on the right is that if you had a nice deep response, you will sustain that response. You will not progress up to 3 years out. If your response were weaker, right, the IgM drops were more superficial, then those patients tend to lose the response a little earlier. And this is a very typical features. We have seen this happening with chemoimmunotherapy and with these treatments as well. So it's not an unusual observation to see. Now the toxicity was very manageable. We actually, if you are not aware of this, when we do clinical trials, we actually measure the toxicities that happen when the patients are having the treatments. And we need to be very inclusive, right? In the minute we think that something might possibly be related to the disease, it needs to be reported, right? So these reports tend to be very, very long and comprehensive, and that's why when you on TV you see, take this antidepressant and they give you like 150 different side effects, it's because of this, because you need to write down pretty much and report every side effect that a patient can have. Now, what they don't tell you is that there are different gradings of these side effects. And you have very mild side effects, and that's a grade 1, which means you feel something but doesn't really affect you in any way, all the way to grade 5, in which you die from that complication. So there are different grades, and that's the greater the grade 3 and 4, the more toxic the medication is, and the lower the grade 1 and 2, then the less toxic the medication is. So in this case, we can see that there are a number of different side effects, but very, very little, very few grade 3 problems. We had one patient with neuropathy, and that was actually a diabetic neuropathy because of the steroids, and then a couple of infections. But all the other patients, all the side effects were actually grade 2. So it's a very reasonable treatment because in patients who had bortezomib, for example, they had a lot of grade 3 neuropathy, a little less grade 2 neuropathy. So that the grading is very important, and that's something that is an important concept to have in mind. It's not a black and white type of situation. Yes or no neuropathies, there are grades to it, for example. Let's move on to another type of treatments. We are all familiar here with Ibrutinib. We have been hearing about that a lot. Ibrutinib belongs to a family of medications called BTK inhibitors because it blocks an enzyme called the Bruton tyrosine kinase. That stands for BTK. So there's a number of studies already published on Ibrutinib in patients who have been previously treated and also newly diagnosed patients with Waldenstrom's, and we can see here the 3 different studies. This is the study by Trion and us at the Dana-Farber, 60 patients, great overall response, major response around 70%, and a PFS that we haven't not gotten to the median yet, 5 years out. So that's a very nice and long survival. And you saw there that the MYD88 patients tend to do better than the CXR4 patients, but when we look at the entire group, we have not gotten to the median yet, passing 5 years. Then we have another study that was the second was an international study in which 30 patients who were not candidates for rituximab because they were refractory to it, were exposed to Ibrutinib as well. Very nice responses, very similar responses, and at a year and a half, more than 86% of patients were still on treatment. And the last one is a study that we did on patients who have not been previously treated. These patients who got Ibrutinib for the first time, and that was their first treatment. And again, the response rate was 100% with an 80% major response rate, and at 18 months, more than 90% of patients were still on treatment and doing well. So we're going to be updating, obviously, all these studies very shortly with longer follow-up, which will be more meaningful in terms of long-term treatments. But they are obviously efficacious treatments. So Dr. Trio mentioned this earlier. There are 2 BTK inhibitors that are coming down the pike at this time. They are both relatively advanced in the clinical development process. One of them is called Calabrutinib. At the beginning, I didn't know how to say it, so I said Abracadabra-Brutinib. So this is a BTK inhibitor that is already approved in the United States for a condition called mantle cell lymphoma. And this is the study that was presented in Sweden last year by Dr. Owen. We can see here, all these were previously treated patients. We can see here very similar distribution of patients. Around 69 was the age, the IgM around 36, and the response rate is 94%. That's a great response rate, with a major response rate close to 80%. So that's a very potent treatment. And the VGPR was around 30%. All this within 2 years. So within 2 years of therapy, we're having very nice responses. Now, the issue is we thought it was going to be markedly less toxic than Ibrutinib. It doesn't seem to be at this time, unfortunately. There's some bleeding issues still and some arrhythmias as well. So I don't think that in that scenario it's going to be too different than Ibrutinib. But definitely an option for patients who have other potential side effects to Ibrutinib, for example, like diarrhea or skin problems or things of that nature. I think maybe this medication might be better tolerated. The problem is that we don't know if for sure will be until they don't write the paper and the paper doesn't get published and it's peer reviewed, so it's formally accepted. So far we have is just some posters and some abstracts, but we don't have an actual paper. So we tend not to recommend treatment on medications that have not been fully vetted yet. So hopefully we'll be hearing about this later this year, so we can potentially start using it and see if that is something that we can use for patients with Waldenstrom's. My sense is going to be effective. It's just a twice-a-day medication. The other one is the one coming from China. It's a medication called Zanubrutinib. Some people know it as BGB3111. Again, it's a twice-a-day medication too. They are very advanced as well in their process. This is the data presented at the same meeting last year. IgM around 32, hemoglobin around 87 at the time of initiation of therapy, and we can see here an overall response rate of 90% at 15 months with an 80% major response rate and 36% very good partial response rate. So really seem very interesting in terms of efficacy. But the AFib is still there and the bleeding problems are still there. I think the bleeding and the AFib are BTK inhibitor side effects. I don't think one agent is going to be better than the other in those specific scenarios. The gastrointestinal issues and the skin issues may be a little bit better, but the other ones are pretty much the same. Now, the company called Beijing got so excited about this data that they actually ran a randomized study. Now, I want to just emphasize how difficult it is to run randomized studies in patients with Waldenstrom's, because we need anywhere between 70 and 100 patients per arm in multiple centers and multiple institutions. in multiple countries to be able to accumulate that amount of that number of patients. So we have not had too many randomized studies, which in breast cancer is just so easy to do, and they have like 15,000 patients per arm, right? It's very difficult to do in patients with Waldenstrom's. So this is a randomized controlled study. I think it's going to be around 80 some patients per arm. Is already accrued, which means all the patients have been accrued, all the patients have been enrolled. There's no more enrollment. Nobody else can participate in this. And the way it was designed is half of the people randomly was assigned to be on Ibrutinib, regular dose, and half of the patients were assigned to be on Zanubrutinib, taken twice a day. So we should be hearing from this later this year, I hope. The idea is that the company feels that this Zanubrutinib might be more effective, and that's what they are basing their study on. Obviously, we will not know if it's more effective until we don't see the data. In God we trust, everybody else needs data. And we will see also if the toxicity, there's any difference in toxicity with this agent as well. So, we actually, Dana-Farber participated in this clinical trial. We enrolled some patients, and we're all waiting for the data and see how good it looks on these patients. So now you have heard earlier about these BTK mutations that make patients with Waldenstrom's on Ibrutinib become resistant to Ibrutinib, what we call Ibrutinib resistance. So just to give you an idea of how this works, in the graph on the upper side, we can see the cell, and then we can see this little pocket here, and it says cysteine there. This is a protein that basically sits in that specific area. It's the point to which Ibrutinib binds to. Ibrutinib, depicted here on red, automatically binds to the BTK in a really nice, in a very nice situation, kind of binds to it and inactivates BTK. That's the way it works. Obviously, this is just a diagram. So what happens in patients with CLL, Waldenstrom's, and other conditions, when they become resistant to Ibrutinib, they develop a mutation in this pocket in a situation that Ibrutinib cannot bind anymore because the pocket has been mutated. All right? So how do we move around that? So one idea is create another BTK inhibitor that will bind to BTK but using a different spot. So even though the mutation is present, it will not affect the efficacy of this new medication. So there's a number of them. I'm just giving you this example of a medication called Vecabrutinib. Vecabrutinib binds to a different spot in the BTK that is not the position 481. So this is actually in clinical trials. We are participating at Dana-Farber on these studies. It's open for patients with Waldenstrom's. If anybody here wants to participate and they are losing efficacy on Ibrutinib, shoot me an email. I'm happy to try to make this happen. I don't know if there's any sites in Canada, but I'm happy to investigate that for you as well. But we do have this. This is undergoing a phase 1 study. Phase 1 means that we don't even know if it's safe. That's what phase 1 means. So we start with very low doses of the medication, and then we keep increasing until the patients become too toxic, and then we go down on the dose, and we say, okay, so this is the one that is safe, and then we will see if it's effective or not down the road. So that's and that's a phase 2. Once we prove that a medication is effective, then we compare it against the standard. That's a phase 3 study. So that's how the phases of the studies move on. So this is a study that is running, if anybody here could be potentially interested. Now, the one that we are very excited about is this medication called Venetoclax. You've heard earlier by Dr. Matus about this process of natural death of these cells. All our cells die at some point, to the point that in our lifetime, we actually renew our cells 7 times. So when we die, we don't have one cell left from when we actually were born. We renew our cells 7 times in our lifetime. That's a very interesting concept if you think about it. In any way, so BCL2 modulates the amount of time that a cell is out there and for how long it's going to live. Now, Waldenstrom cells, as well as 75% of other cancers in humans, do have an excess of BCL2, and therefore they immortalize themselves. They don't die when they are supposed to die. So Venetoclax comes into place. Venetoclax is a BCL2 antagonist. It basically goes in and fights BCL2 down. And by doing that, we believe it actually forces those malignant cells to die, which is a little bit different than what Ibrutinib does. Ibrutinib goes in, it kind of modulates the function of the cell, right? Inactivates the cell, but it doesn't really reduce the number of those cells in a dramatic manner. So therefore, when we stop Ibrutinib, the disease kind of wakes up again, right? So this is more like an inhibitory function. Venetoclax, we believe, is actually potentially killing those malignant cells. And we started at a dose of 200 milligrams for a week, then we went up to 400 milligrams for a week, up to 800 milligrams for a week. And the idea was to give this medication for 2 years and then stop treatment. So not only is a pill form treatment, it is a finite pill form treatment. So this study is already enrolled completely, and we're actually following those patients along, and we're going to be probably showing some data later on, more definitive data later on. But I want to show you today is the data that I presented at this meeting in Sweden last year, and I think I presented this also at the WMF last year meeting. So in any case, we put 30 patients on this study. There were 4 centers in the United States. Dana-Farber and Cornell, as well as Stanford and City of Hope. So again, 57% men, men tend to have this disease a little bit more than women. 100% of the patients were Mid88 mutated. We did not have any Mid88 wild type in this study, and about 50% of patients had CXR4 mutations. These are the responses up to a median follow-up of 1 year. So this is just half of the way, and we had a VGPR of 13%, 43% of partial response, with an overall response rate of 80% and a major response of 56%. Now, I'm actually working on the more recent data, which is about 15 months or 16 months into this. These numbers look even better, but I cannot give you the numbers because of confidentiality. So these are the waterfalls, which means the longer the line, the more effective the medication is. And you can see here how 80% of people do benefit from this. Now, I put this graph in here because the yellow bars are the patients who were coming out of Ibrutinib. They were failing Ibrutinib and they got into Venetoclax. And the blue lines are the patients who did not have any Ibrutinib exposure previously. And you can see here that across the board, everybody responds, regardless if they had exposure or did not have exposure to Bruton tyrosine kinase inhibitors or Ibrutinib, they are responding to this medication. So this is an exciting part of how efficacious this medication is, regardless of prior exposures. The second graph that I want to show you is based on the CXR4. The red ones are CXR4 mutated, and the blue ones are the CXR4 wild types. And we can see here that, again, across the board, regardless if you have CXR4 mutations or not, Venetoclax seems to work on these patients as well. And obviously, the longer the curve, the line, the deeper the benefit the patients are obtaining. Now, the kicker here is this. This is the amount of bone marrow disease at the moment of initiation of treatment, and then at cycle number 6, and then at cycle number 12, because this is as far as we went. We went to cycle 12 only. In the clinical trial, we're going to go all the way to cycle 24, so we will see those data later. But we can see here how the average bone marrow involvement was around 40% and dropped down within 6 months to 5% and remain at 5% at a year later. So this is a suggestion to us that we are really killing those malignant cells. Not only modulating, not only inactivating them, but we're actually killing them. So that's exciting. Now, this is the depth of response based on prior Ibrutinib and CXR4 mutations. This is basically a table telling you the other one. And this is the toxicity. So grade 4 means a very low levels of white blood cells. That's what we have seen with Venetoclax. And that is actually something that has been seen in many other studies, not only in Waldenstrom's. This is just how Venetoclax operates. But only 3 out of 30 patients, those patients were heavily pretreated, so maybe that's one of the reasons. And we can consider actually the dosing of Venetoclax being one of the reasons for this. In a couple of patients, we have to decrease the dose to 600, and another patients to 400 milligrams, and with a good success. None of these patients got infected. None of these patients got admitted with infections. None of these patients developed fevers. So it's just a number issue, much more than an actual clinical impact. And then grade 3, again, neutropenia, that's expected, the low white blood cell counts, a little bit of anemia, and one person had a bad flu infection. But otherwise, all the other side effects are grade 1 and 2. And again, since this is a finite duration treatment, we don't expect these side effects to, to be durable. Once the treatment stops, then those side effects actually do stop as well. So really encouraging data in terms of efficacy and in terms of safety with Venetoclax. Again, I am not recommending patients going into Venetoclax right now. The paper has not been accepted for publication, hasn't even been submitted, right? So we need to be careful and mindful. It's good to know that there's something out there, but the treatment has to be studied or has to be, given once we know that it's actually effective, has been fully peer reviewed, has been fully vetted, the data has been reviewed, the FDA has approved it. So there's a number of different steps to be able to actually get these medications. But as it stands, I think it's going to be a very active treatment for patients with Waldenstrom's. We're so excited about this that we are actually planning a clinical trial combining Ibrutinib and Venetoclax. In the laboratory, we have been able to show that when you block BTK and BCL2 at the same time, the death cell is much higher to the point of being synergistic. So it's not only additive, it's actually synergistic, which means both parts and then a little bit more in addition to that. So we're doing Venetoclax 400 in those patients. We're not doing 800. With Ibrutinib 420, so that's about 5 pills per day for 2 years, and then stop treatment at that moment. And that's a study that we're going to be starting at the Dana-Farber sometime in July or August of this year. It's going to be only previously untreated patients. Previously treated patients will not qualify for this study, and we are thinking that about 50 patients will do, of which at least 20 has to be CXCR4 mutated patients. So that's our design for this study, and we're looking forward to open it. We're in the last processes of getting it running. So this is how we understand now Mid88 and CXR4. And this graph is not to confuse you. It's basically I'm trying to show you that the pathway of MYD88 on the left and the pathway of CXCR4 on the right, they are semi-independent. If you look at it, they almost do not interact with each other. Almost at the end is when they do interact and they start doing all these survival pathways, through nuclear factor kappa B. But at the end, it seems to be that they are two separate pathways. And again, this is how science impacts the clinic. When we started the study on Ibrutinib, which blocks BTK, we knew that the patients with CXR4 mutations were not going to do as well. Why? Because that other pathway is still activated. And I think Dr. Trion alluded to that earlier in the presentation. So we are actually thinking, how can we improve that? And one of the initial steps is Dr. Trion presented this, is to say, well, we're going to block Ibrutinib, we're going to continue on Ibrutinib, and we're going to block CXCR4 by adding an antibody called Willebrand. We are now about 10 patients into our clinical trial. Our clinical trial is a goal of about 25. We are seeing nice responses. We're seeing rapid responses. I cannot give you many more details about this. We're seeing some low platelets with this treatment. And this is pretty much all I can say for now. But it seems to me that this is something that is potentially exciting, specifically for patients with CXR4 mutations. So for this study, the patient has to be CXR4 mutated. We are not taking patients without CXR4 mutations. So this is a study that we are running at this time, and we are enrolling patients actively at the moment. So for your consideration. The other approach that we're thinking about this is, well, what about blocking other pathways that are not the CXCR4, but has to do with the CXCR4 pathway stimulation? And in this specific graph, we can see how these patients are on Ibrutinib, and this is a study that Dr. Trion also mentioned. But we're actually kind of trying to block this pathway called ERK, E-R-K. So there are a number of ERK inhibitors out there, a number of them. And the one that we're going to be using for a clinical trial is this LY3214996. So that's the one that we're going to be doing in patients. If the patient is progressing on Ibrutinib, the patient will continue on Ibrutinib, and we will add this LY medication to these patients to continue in a clinical trial. This medication is a pill form treatment, if I'm not mistaken. But there are others out there. There's one that actually has a name called Willebrand, and there's another one from other companies, PD98059. So there's a number of ERK inhibitors that are going to be coming down the road. And I think this model of adding it to Ibrutinib actually makes a lot of sense in these type of patients too. So that's another study. This is not open yet, but we're going to be opening it very shortly. We do have the funding and the contracts have been signed. Obviously, until it's not out, I cannot tell you, yes, this is an option for you, but that's some things for you to know about. Now there's another one, another pathway called the PI3K pathway, which is a very important pathway to block coming out of CXR4 mutations. And not only is important in that setting, we see that even patients who do not have the CXR4 mutation also have PI3 kinase activation pathway. So there are a number of PI3 kinase inhibitors out there, but most of them are very toxic. We did a study previously with another medication called idelalisib that didn't do too well. There was a lot of liver inflammation. But this medication, umbralisib, seems to be much more benign in terms of the toxicity. So this is another clinical trial that we have open for patients who have failed ibrutinib, coming out of ibrutinib, getting into these also a pill treatments once a day, umbralisib. That's another clinical trial that we have open for this type of patients too. So we're really focusing, as you can see, a number of our studies are focused on patients who are actually failing ibrutinib, because I think that's an unmet need in terms of what to do with those patients. So this is the design of the Ibrutinib and Willebrand study that I was mentioning earlier. It's about Willebrand, which is the antibodies, once a week for the first month, and then every other week for 5 months, for a total of 14 infusions over the first 6 months of treatment. And then Ibrutinib continues indefinitely as it would otherwise. And again, patients have to be CXR4 mutated for this study. And to finalize, and I'm going to just give you a good time for questions, is this antibody called Daratumumab. Everybody here is familiar with rituximab. Rituximab is an antibody against a marker in the membrane called CD20, which is very typically present in the B cells. Now, CD38 can be present in the B cells, but also is present on the plasma cells. That is the ones that produce the IgM. So there's interest on this medication because we think we're going to be kind of targeting the other side of the clone rather than the other side of the clone that rituximab does. Now, antibodies have multiple effects, as you can see there. It actually activates your immune system, so you can fight the malignant cells in a more effective manner. So Daratumumab will do exactly the same, but targeting a different target than rituximab does. Now, in myeloma, which is obviously the bad cousin of Waldenstrom's, has already shown to be very effective. We have a response rate of 30%. These are patients who have went for transplants. They have all these other treatments, all these chemotherapies, got Velcade, got all the treatments that they are supposed to have. There were not other options for these patients. And in these patients, 30% of those patients responded to Daratumumab. So we are very excited about this and see if that translates into the same efficacy, or at least more efficacy, in patients with Waldenstrom's. There's a study from the Mayo Clinic in the laboratory that showed that this antibody was very potent on killing malignant Waldenstrom cells. So we are running a study right now at the Dana-Farber. We have about 10 patients enrolled. We also open it at the Mayo Clinic. It is also open at Stanford and Seattle. So in this study, Daratumumab is an antibody given in the vein, and is given once a week for the first 8 weeks. That's a little bit challenging. And then every other week for 16 weeks, and then monthly for a year. This is basically mimicking how Daratumumab is given to patients with myeloma, with the difference that in myeloma you continue treating those patients indefinitely with Daratumumab monthly all the way to progression. But in Waldenstrom, we decided to stop it at 1.5 years of therapy, and we'll see how that works in the future. So we have about 10 patients enrolled on this. We're seeing some early efficacy, and we will probably be providing more information as time goes by. So I think this is my last slide. So I just want to conclude by telling you that this is just the beginning of all the different treatments that are available, newer treatments. I mean, all these, I just mentioned at least 6 or 7 molecules that have a complete different mechanism of action of whatever we have available at this time. So it's just an idea of how the field is opening up, so we can try these new medications, but all this will not be possible and cannot be driven if we wouldn't have the laboratory data and obviously the support that is being provided by the different foundations. So with that, I want to thank you for your attention, and I'll leave alone for questions.